Hello everyone, my name is Julian Marie Wanilio and I am from Group 4. Our topic is presented on the screen, but before we begin our discussion, I will give you a short introduction about it. So as we all know, premature, also known as preterm birth or simply PT, is when a baby is born too early or before the 37 weeks of pregnancy have been completed. So PT is a phenomenon that affects a large and variable group of newborns due to its many underlying causes. According to a 2010 estimation by the World Health Organization, approximately 15 million babies are born preterm worldwide each year. In the Philippines alone, an average of 348,900 infants are born PT annually. PT birth is known to be the leading cause of newborn deaths. But thanks to advances in modern medicine, premature babies may now have a better chance of survival. However, survival is not the only outcome measure. The vast majority of babies born before 37 weeks are still vulnerable to increased risk of mental or developmental disabilities. For today's discussion, we will talk about the multiple developmental disabilities that are common in premature or preterm infants. The following are our objectives. First, we will be discussing about the etiology. Next is the prevalence and incidence. Third is the signs, symptoms, and pathomechanics. Fourth, the types, course, and prognosis. Next is the management, the existing support system in the Philippines, and lastly, the problems in SLP areas that may arise. First, let's talk about the etiology. So the following are the common causes of multiple developmental disabilities in premature infants. First is neuroanatomical factors. Studies have shown that cerebral abnormalities associated with preterm birth may be a substantial determinant of cognitive and language development. Second is atypical functional brain organization. Variations in cognitive, language, and speech development are likely to be the result of underlying abnormalities in the brain associated with functional organization outcomes. During normal development, language organization is extensive and bilateral in an infant's brain. Later, with increasing age, it becomes more lateralized in the left hemisphere. In healthy 3-month-old infants, mature cortical areas are active when processing language. By this time, speech perception is already left lateralized with activity in the superior temporal gyrus and the angular gyrus. In preterm newborns shortly after birth, on the other hand, an asymmetry in the areas surrounding the perisylvian fissure is found, suggesting that specific anatomical organization favors functional lateralization even before language exposure. This includes a larger depth of right-sided superior temporal sulcus and a left shift of the planum temporal. Third is structural abnormalities. Approximately 50 to 70% of preterm born infants are affected by diffuse white matter abnormalities such as loss of white matter volume, corpus callosum thinning, and delayed myelination. The presence and severity of these cerebral injuries increase the risk of later neurocognitive impairment in preterm children. In a recent study, it was reported that the mean score on language tests at the age of 4 and 6 years significantly declined as severity of white matter abnormalities increased. Fourth are postnatal environment factors. Considering brain development is mostly shaped by early sensory experiences, exposure to language in the infant's environment is of most importance. Since preterm born infants are exposed earlier to the environment outside of the uterus, one can wonder what the impact of this early exposure to the auditory environment has on the developing brain. Fifth is exposure to auditory stimuli in the NICU. When born prematurely, infants spend the first weeks or even months of their life in the NICU. During this critical period for development, they are deprived of the sounds they would otherwise be hearing in the utero. The intrauterine environment allows the fetus to perceive low-frequency sounds in an attenuated fashion, ensuring the development of the auditory system. However, when born preterm, infants are prematurely led into a more invasive environment which can have profound effects on the auditory brain maturation and subsequent speech and language acquisition. The NICU environment may also be too loud for the infants to reside in. While being placed in an open room, they are exposed to unpredictable, multiple high-frequency sounds, such as from electronics or machines, and voices coming from parents, nurses, and doctors, which may prevent them from being exposed to meaningful and infant-directed language inputs. Excessive exposure to loud ambient noises can also negatively affect the infant's physiological stability. It could affect their cardiovascular and respiratory systems, which in turn may cause a risk for neurodevelopment. When placed in an incubator, The environment can also be too quiet, limiting the ability of the infant to perceive language stimuli. Lastly, we have dysfunctional caregiver-infant relationship. For infants residing in the NICU, full-time parental presence is not the case. Dysfunctions in early social communication due to long periods of separation in the NICU can have negative consequences on an infant's behavior and emotional and physiological well-being. Moreover, an important aspect affecting language development in preterm born children is the quality of the infant caregiver relationship. Multiple studies show that when a child and their caregiver participate in quality interactions, language development will improve. Increased psychological stress experienced by mothers of preterm infants has been linked to differences in mother infant interactions in this population. Now let's discuss the prevalence and incidence of multiple disabilities in preterm infants. Every year, an estimated 15 million babies are born preterm. That is more than 1 in 10 babies, and this number is continuously rising. Across 184 countries, the rate of preterm birth ranges from 5% to 18% of babies born. Preterm birth complications are the leading cause of death among children under 5 years of age, responsible for approximately 1 million deaths each year. Inequalities in survival rates around the world are stark. In low income settings, half of the babies born at or below 32 weeks die due to a lack of feasible, cost effective care such as warmth, breastfeeding support, and basic care for infections and breathing difficulties. Multiple disabilities are 2 to 3 times more likely to occur in premature infants compared to full term infants, and this rate of disability is higher in boys than in girls.
Okay, now I'm going to discuss about the signs, symptoms, and pathomechanics of premature infants. So for the signs and symptoms, they are usually small in size. Premature babies often weigh less than 5 pounds 8 ounces, and they have thin, shiny pink or red skin. You may be able to see the veins through the skin, and they also have little body fat, little scalp hair. But the baby may have lots of soft body hair called lanugo, and they also have a weak cry and low muscle tone, and the male and female genitals are small and not yet fully developed. So for the multiple developmental disabilities acquired later by these premature infants, so usually they have simultaneous impairments. So they can acquire like intellectual disability and blindness at the same time. And their speech and communication skills are also hampered. They also have challenges with mobility, and so they need assistance in performing their everyday activities. And their severe educational needs cannot be accommodated in a special education program solely for one of the impairments. So going on for the type scores and prognosis. So premature babies are born before 37 weeks of pregnancy, and the earlier the baby is born, the higher the risk for multiple developmental disabilities. So they are categorized as this. So first, they're the early term infants. So babies are usually born between 37 weeks and 38 weeks 6 days. And we have the late preterm infants who are babies born between 34 weeks and 36 weeks 6 days. There's also very preterm, born up or below 32 weeks, and extremely preterm, which is or babies born or at or below 28 weeks. So basically, the earlier the baby is born, the higher the risk for complications such as acquiring multiple developmental disabilities. Therefore, extremely preterm babies have a higher risk of developmental disabilities compared to early term babies. So let's go to the um, multiple developmental disorders associated with prematurity. And the main developmental disabilities associated with premature include cerebral palsy, intellectual disability, ADHD, ASD, hearing loss, and visual impairment associated with retinopathy of prematurity. So first we have the cerebral palsy. So cerebral palsy, with various intensities and types, is the most common developmental disorder of preterm infants and is associated with long-term disability. So early signs of cerebral palsy usually appear before 3 years of age, and infants with cerebral palsy compared with normal children often have slower developmental changes or slower developmental stages. So for the intellectual disability, in general, premature babies score lower on a variety of tests that measure intellectual ability, and how much lower they score is in direct relation to how premature and small they were at birth, and if they suffered complications affecting the brain immediately following birth. So for the ADHD or deficit hyperactivity disorder, ADHD consists of a multifactorial interplay of genetic and non-heritable factors, as we have learned from the previous group. So persons who were born um, very extreme, premature, and or very extremely low weight were about 3 times more likely to receive an ADHD diagnosis than those who had term normal weight births. So whereas the risk was doubled in the very premature low birth weight, it was quadrupled in the extremely premature low birth weight. So for the ASD or the autism spectrum disorder, so extremely premature babies run a much higher risk of developing autism in late childhood. They are exposed to numerous stress factors during a critical period to brain development, and it is possible that this plays a key part in the development of autism spectrum disorder. So for the hearing loss, the infant's admission to the intensive care unit increases the risk of both types of sensory, neural, and conductive hearing loss. So being exposed to ototoxic drugs, infection, injury, hypoxia, ischemia, and increased serum bilirubin are also important factors in decreasing hearing in low birth weight infants. So for the visual impairment, retinopathy of prematurity is one of the most causes of visual loss in infants with low birth weight. So gestational age of less than 26 weeks is the most important factor associated with visual impairment. Since that hypoxia, arterial carbon dioxide pressure changes, arterial pH, this is pH is used to measure how acidic or basic the water is, and oxygen consumption with high dosage and being exposed to light are influential factors in visual defects in infants with low birth weight.
Good day, everyone. I will be reporting on management up to speech language hearing and or swallowing problems in relation to prematurity. So, for management, we have medical and surgical, critical members of the management team, and medical precautions regarding speech language therapy. First up, we have medical and surgical. Here are the management and treatment for premature infants in general. We have corticosteroid medicine for the mother to help the baby's lungs and other organs grow and mature before birth, watching the baby's temperature, blood pressure, heart and breathing rates, and oxygen levels, having a temperature controlled bed, ventilator, intravenous fluids, feedings or medicines, special feedings with a tube in the stomach if a baby can't suck, x rays or other imaging tests, and kangaroo care. So, this is prior to discharge. Upon discharge, however, the parents or the caregiver needs to take note that premature infants are at a high risk for sudden infant death syndrome. Therefore, they should be put down to sleep on their back. We also need to take into consideration that premature infants are at a high risk for multiple developmental disabilities, as my group mates have discussed. Therefore, we should take into consideration that a comprehensive and systematic approach for assessing the severity and impact of the multiple developmental disorders on daily functions is necessary. And we can do this by implementing programs for early intervention and providing special education for these children later on in life. Next up, we have the critical members of the management team. We have the neonatologist, who specializes in caring for premature and other newborn babies, the pediatric surgeon, who specializes in children's surgery, the registered nurse, who provides direct care to the premature baby at the bedside, and the clinical nurse specialist, who is also a registered nurse. But the only difference is that they actually specialize in caring for premature and other newborn babies and their families. We have the respiratory therapist, who provides oxygen and breathing support to premature babies who have breathing problems. And finally, the speech language pathologist, who has expertise in human communication and swallowing disorders. Medical precautions regarding speech language therapy. So, studies reveal that aspects of infant care in the neonatal intensive care unit, like positioning in the isolates and the amount of ambient noise in the room, can actually affect the premature infant's ability to perceive and consequently to adopt to the sounds of speech. That's why they recommend low noise environments in the neonatal intensive care unit. And since these premature babies have a high risk of acquiring multiple developmental disabilities, they may require early intervention and special education services, like I've mentioned before. Moving on to existing support system in the country for persons with this condition. We have the Z benefit package for prematurity and low birth weight babies from PhilHealth. So in this photo, you can see the launching of the event, PhilHealth in cooperation with the World Health Organization, UNICEF, and DOH. So this particular package includes coverage for corticosteroids, medicines to prevent eclampsia, transfer of the mother to the nearest referral facility, and other interventions to prevent complications related to prematurity and low birth weight. So how can a mother avail this particular package? First, the mother needs to be, of course, at risk of giving birth at 24 weeks to less than 37 weeks of gestation. And this can also be availed by premature newborns who are visually small, meaning they are 24 weeks to less than 32 weeks by fetal aging, or 500 grams to less than 2,500 grams fetal weight, and preterm and small newborns who are 32 weeks to less than 37 weeks by fetal aging. They're also entitled to this particular package. Finally, we have speech language hearing and or swallowing problems in relation to the above condition, which is prematurity. So first, we have hearing problems. Prematurity is actually responsible for 25% of instances of cognitive or hearing impairment. And moderate and mild sensorineural hearing loss, that's from 25 decibels to 59 decibels, can lead to delayed speech and language development with the incidence of 6% to 8% of low birth weight infants. So you can see that prematurity causes hearing problems, which in turn causes speech and language problems. For speech and language problems, there is reduced speech quality, poor articulation, and also phonological impairments. They may also have difficulty understanding others and learning new words and saying them properly. Finally, we have swallowing problems. These children have an increased risk of experiencing feeding difficulties. Why? Because they have to reach the 40 weeks mark for all of the muscles required for normal feeding to be fully developed. And as we all know, these premature infants, they have had problems with organogenesis, so they may have had underdeveloped muscles and organs. So here are our references. That ends our report. Thank you for listening. And if you have any question, don't hesitate to ask us during the integration. Thank you.